these meetings. So you'll see the pop-up on your screen. So please just go ahead and click yes to that. Yesterday, everyone should have received an agenda for this morning, but we'll go over it really quickly. Here's your welcome right on the top. We're so glad to have you here today. My name is Kate Shamzad, and I work as the Director of Policy at the Quality Institute. I'll be one of your moderators today, along with Linda Schwimmer, who you'll meet in a few moments. And we're very pleased to have a number of co-facilitators who are really experts in data, equity, and maternal health. So I'll be introducing them in just a moment. The first half of today's session really focuses on our co-facilitators presenting some expert content. And then the second half of today will allow all of us to dive into the work. Linda's going to go over in a few moments exactly why we're here today and what the map is and what we're hoping to achieve. But in the meantime, I'd love to introduce our speakers. So today we have with us Dr. Damali Campbell. She's a physician board certified in both obstetrics and gynecology and addiction medicine. For almost 2 decades, she's dedicated her practice to improve the care for women in underserved areas and pregnant women struggling with addiction. Dr. Campbell is also a physician lead for her medical center, and is the first in Essex County to achieve the baby-friendly designation. Since 2007, she's been a committee member for the New Jersey Maternal Mortality Review Committee, which is a volunteer multidisciplinary group that reviews each death of a woman within 365 days of a pregnancy, regardless of the location of the pregnancy. This work has led her to be part of various work groups in New Jersey, including the First Lady's Nurture New Jersey Summit. And she served as a speaker for the U.S. Surgeon General's listening tour on maternal mortality. As of May 2020, Dr. Campbell serves as the medical director for the New Jersey Maternal Care Quality Collaborative, or the MCQC. You'll hear us use a lot of abbreviations today. So if you don't know what one is, stick it in the chat. This is a CDC grant received by the New Jersey Department of Health. In this role, she is the maternal child health advisor to New Jersey Department of Health. She's also a member and the 2023 chair of the New Jersey MMRC. Our second speaker today is Helen Hannigan. She's the executive director of the Southern New Jersey Perinatal Cooperative and president and CEO of Family Health Initiatives, or FHI. She leads work to improve health services and outcomes for women, infants, and families across Southern New Jersey. Hannigan has over 20 years of experience designing and implementing initiatives that focus on high-quality data to respond to health and social needs of individuals and communities. Hannigan received her Bachelor of Science in Sociology from St. Joseph's University in Philadelphia and her Master's in Government Administration from the University of Pennsylvania. We're so glad she made the hop over to New Jersey. Kimberly Seals-Allers is an award-winning journalist, 5-time author, international speaker, strategist, and advocate for maternal infant health, and she's our third speaker today. A former senior editor at Essence and writer for Fortune magazine, Kimberly is a leading voice on the racial and socio-cultural complexities of birth, breastfeeding, and motherhood. She's the founder of Earth, a new Yelp-like app for Black and Brown parents to address bias and racism in maternity and infant care. And she also created Birthright, a podcast about joy and healing in Black birth that centers on positive Black birth stories as a tool in the fight for birth justice and reverses the narrative of negative statistics common in mainstream media coverage of Black maternal health. You can follow Kimberly Seals-Allers via Facebook, Twitter, and Instagram at IamKCAllers. We're so thrilled to have these 3 speakers here today, and I'll turn things over to Linda Schwimmer to tell you a little bit more about our goals.
Thank you, Kate, and welcome everyone. I'm Linda Schwimmer, President and CEO of the New Jersey Healthcare Quality Institute. And what I'm going to do is go over for you, if you don't already know, what the map is, what the purpose of our map to action work is, and then some details about this particular session and the sessions to come. So the map. The map is an action plan that the Quality Institute released last summer. It's really meant to provide literally a map, a directional guide forward for all of us, for all of you, to work to implement the Nurture NJ strategic plan. This is the first of 4 sessions we're going to be hosting. Each session is focused on one of the 4 sections of the map, and then we will all be convening together on March 3rd, which I'll get into a little bit. Next slide. So I'm not going to dive deeply into each section of the map. Just note, because we sent you the link to it, we also sent you an executive summary to it. And at the start of each session, or the day or two before each session, we're going to be sending you also an executive summary of that particular section of the map, so you'll be ready. But basically, the first section is the workforce health section, and in that, our work session in talking about the workforce we need to achieve birth equity is going to particularly focus on education, anti-racism education, and the maternal infant workforce that we need, with a particular focus on the community-based providers and individuals that are listed below under number 3. But that's not for today. So we can go to the next slide. The second session of the map really focuses in on data and the importance of having data and using data in this work. And today in particular, we're going to be focused on both collecting timely data, how that's made available, and then making sure that we have patient experience data. Next slide. Okay, the third section of the map really talks about reforming our payment system to drive high quality, holistic maternal infant health care. And we are going to be in that session, we're going to be hearing from Medicaid about how it's doing that through its maternity episode of care. We're also going to be particularly focused on scaling existing models that we know are successful and working, but need to be integrated into the payment system. And then the fourth section of the map is focuses on, we all know that this is not just about the medical system. In fact, it's largely not about the medical system in many ways. We're going to be focused on the community-based social supports and issues that we need to address. And in that session, we're going to be hearing about legal medical partnerships and really how to get access to a lot of services. And we're also going to be hearing about and discussing existing Title V programs and the support and scale that they need. Next slide. Okay, so for today, again, I want to echo Kate in thanking our speakers. We are going to be identifying work that's already in motion. We're hoping to increase awareness of that work. We're going to be hearing from all of you about the opportunities as well as the barriers that you see. You're going to be hearing from Dr. Campbell, then you're going to be hearing from me. I'm going to be sharing some information about Leapfrog data. Then you'll hear from Kimberly and Helen about patient-reported or patient experience data. And then we're going to break into 2 work sessions, and you're going to have your choice as to which session you'd like to jump into. And that's where we're really going to get in a deeper discussion. You'll be able to ask the speakers questions. You'll also be able to share the work that you're doing and share work that you'd like to be doing. We're going to come back together after that. And if you didn't get to join, if you feel like, wow, I want to really be in both sessions, don't worry, because when we all meet on March 3rd, you're going to get the opportunity to be in both of these sessions, because we're going to be talking about these issues in greater depth. I also want to make sure that you saw that in your pre-read information, we sent you a worksheet. The worksheet that we sent today is going to be very similar to the worksheet we're going to send you for each of these sessions. It's a template for you to fill out and for you to share with colleagues within your organization who might be working on maternal infant health, but maybe in a different aspect of it. We'd like you to share it with them to fill out as well. And all of those worksheets are going to be returned to Brianna. We are going to be using them to really build out this work plan. The idea behind all of this is, and I know it feels like a lot of moving parts, but by the third one of these sessions you attend, you'll be like, oh yeah, Linda's explaining the worksheet again. The idea is, we know that many of you are doing fantastic things, but you don't all know who else is doing really important work. We know that all of you feel like, boy, I could do even more if I had X or if I had Y. We want to hear about that because we want to put those pieces together to help each of you together collaboratively to really grow and build the change that we want to see. As Professor Ruha Benjamin from Princeton says in her recent book, this is really viral justice. This is each of us doing the work that is in our lane that we know that we can do, but then amplifying each other and building it into something even bigger together. So we're excited about today. I've taken up a lot of your time already. So at this point, I really want to turn things over to Dr. Campbell, who is going to walk us through the data we have, the data that we're using, how it's going to be used, how it is being used, and we'll take it from there. So Dr. Campbell, you are up, and thank you for being here with us.
Thank you for having me. So glad to be here and see many familiar faces. You can go to the next slide. I hope everybody can hear me. Kate, can you just give me a thumbs up if my voice is good? Thank you. So I have no financial disclosures. Like many others doing some of this work, I do have the lived experience of being a New Jersey birthing person who gave birth to 3 children while I was living in New Jersey. I'm still living in New Jersey. One was born too soon and passed away after 6 months, and 2 remain living. And so when we talk about statistics, I'm one of those statistics. And I hope that, you know, as we talk about some of this work, I want to just say, you know, the statistics are there and we can use them in a meaningful way, but I don't consider myself just a statistic. I'm a human being. And I know that each one of these women and families that we discuss are human beings. And, you know, I want to keep that in our mind's eye. I also want to just forward that in this space, the intersectionality of race and gender, I realize that often my work is not valued as much as others because of my race and gender. Next slide. So the New Jersey Maternal Care Quality Collaborative is charged to assess and translate data into actionable cross-sector change. And as we strategize on future activities in line with the federal and state-specific program objectives, you know, we ask, where does that data come from? The Maternity Action Plan calls to collect and use data to improve equity and quality. And so there are various sources of data. We have the New Jersey Maternal Data Center. And that data center is actually really still in development. But what we do have at the current moment is the maternal health report card. The outcomes from that really come from hospital discharge billing data and the electronic birth certificate data. The New Jersey PQC produces data that's available on the New Jersey Hospital Association website. And then there's also the New Jersey State Health Assessment data, which is available. And it's all of this is publicly available. So I have like little screenshots and anybody can Google these things and, you know, kind of go in and get different information. The maternal data center, as I said, is still in development, but we hope to leverage some of the same data, but report on different aspects of maternal health that could have the ability to benchmark similar sized institutions or institutions that have similar resources. Next slide. So I just wanted to take a little closer look and walk through quickly some of the data that is or currently available on the New Jersey Maternal Health Hospital Report Card. The latest report is available from 2019 based on just over 94,000 births. And we can see here, you will note that 1/3 of the delivery hospitalizations were covered by Medicaid. Next. 11% of mothers had pre-gestational and gestational diabetes. And as you saw in the last slide, and you see in this slide, we do have data that is broken down by a variety of ethnicities. 9% of mothers had chronic or gestational hypertension, and we see that there are disparities observed in different ethnicities. Next slide. This slide shows that prenatal care, when prenatal care was initiated, and again, we have various ethnicity data available, but for most people, care was initiated in the first trimester, although we can see that rates can still be improved in certain ethnic groups. And, this can lead us to look into why there's lower initiation rates, and likely because of issues of access and getting insurance for some. Next slide. So this slide, we continue to need to work on reducing the birth of low birth infants and the birth of premature infants, particularly among African-American women. We are way over our statewide rate. Next slide. And while our C-section rates have dropped, and this is again 2019 data, we know that 2018 to 2019, our C-sections rate dropped. In 2019, it dropped to 33%. It's dropped further, although that data is not publicly published on our New Jersey website. Our goal has been to lower the C-section rate to 23.9. What I think is important from this slide is that mothers that experience a C-section, out of all the mothers that experience a C-section, the primary C-section, 83% will have a repeat C-section without a trial of labor. And so we need efforts that will be focused on preventing the first C-section, but also making sure that those women who are candidates for a trial of labor have an opportunity to have that trial of labor. Next slide. When we have data, we can have snapshots for a particular year. So in this particular data slide, we're seeing all of our 49 birthing facilities and their VBAC rate for 2019. Next slide. And other times we can see trends over time. So in this slide, we're looking at severe maternal morbidity with and without transfusion from 2011 to 2019. And we actually see that maternal morbidity from severe maternal morbidity is increasing in all three of those categories. Next slide. Knowing the top diagnosis of several of severe maternal morbidity is really important for knowing what those diagnoses in New Jersey birthing people, because it can help us to direct strategies. Next slide. And so users can go to the website, see information by individual hospital. And again, this outcomes data is drawn from hospital discharge billing data and the electronic birth certificate. Thank you. I wanted to talk a little bit about the Maternal Mortality Review Committee. And there are many ways, because we hear a lot about maternal mortality. We see lots of reports and statistics, and often I get lots of questions. Well, how come this person said that? And then this report says something else. So we have to realize that there are three major sources of maternal mortality data. One is from the CDC and the National Center for Health Statistics. So the data source is only from death certificates, and the time frame is during pregnancy and up to 42 days after pregnancy. And so that is the source of the information. It gives us quick information, but if those death certificates are not complete, or not accurate, then that's the data that we have. And it definitely usually just indicates pregnancy-related deaths. The next source is the CDC Pregnancy Mortality Surveillance System, what is also called PMSS. This is death certificates linked to fetal death certificates and birth certificates. This is looked at from the CDC during pregnancy up to 365 days. The CDC medical epidemiologist look at these linkages. They analyze clinical factors associated with deaths, and then they publish that information to lead to prevention strategies. But we know that maternal mortality review committees on the state level are the most accurate source for state and local data. In our state review committees, we receive data from again, death certificates linked to fetal death and birth certificates, medical records from the hospital. We also try to get the prenatal records, autopsy records, the perinatal risk assessment, DCP&P records more recently, and informant interviews more recently. If those are available, we use all of that information, and the committee reviews all of that information for any woman who is pregnant and to the termination of her pregnancy, however that pregnancy is terminated, as long as we have information about that up to 365 days. The committee is multidisciplinary. And so we also make determinations about whether the death is pregnancy associated, pregnancy related, or not pregnancy related.
Dr. Campbell, we have a comment in the chat from Lisa Block, and she was asking if you could comment on what is known from 2020 on in comparison.
As far as maternal mortality?
I believe, does this include suicide postpartum?
So because, so we will only have information about 2020 from the PMSS system, because our maternal mortality review committee is in the process of reviewing the 2020 deaths as we speak. So the reason, again, why there's a lag time, we have to wait for the entire year in order to look for what the CDC and New Jersey defines as a pregnancy-associated death. And then we collect all of that data before we review those cases. So we have data, but it's not complete, so it's not going to be published as yet on the New Jersey state side.
Thank you.
We can go to the next slide. So just to understand a little bit about the maternal mortality review committee process, again, there's the first case identification, maternal death certificate, pregnancy box checkoff, the linkage between maternal death files and birth and fetal death files. There's a linkage between the maternal death files and hospital discharge files. Then there's a standard data collection. And so we have abstractors who try to collect all of the hospital records, and then they use a standard abstraction tool from the CDC, and they have to extract data for that hospital chart, prenatal records, and all the sources that I mentioned. They have to extract all that data. And then once all of that data is abstracted, and you can imagine that it takes a little bit of time as they request for records, and then they receive records and they abstract the data. So once they receive all of that data, then that data, they present a case summary, and that case summary is given to the multidisciplinary committee. And then we examine those cases, and then we actually use what's called the CDC has a Maria tool. It's a worksheet. Again, it's available on the CDC website, and that we answer 6 key questions about whether the death is pregnancy associated, pregnancy related, whether we think the death is preventable, and then we really try to spend a lot of time in talking about actionable items, that recommendations for improvement. Those improvement items are compiled, and then we create a report that is presented to the Department of Health, to the CDC, and then ultimately the ideas should be presented to the MCQC, the Maternal Care Quality Collaborative, to move data to action. And so I think Linda just put in a chat that the most recent data report is from 2016 to 2018. And people often ask why we don't have more recent data and why we don't have data on a yearly basis. So any death, again, of a woman is a death too many, but because we have many counties in New Jersey, we have to follow certain rules and regulations about publishing data to maintain anonymity. So we don't ever publish data in a yearly basis in order to maintain patient anonymity. So we typically have been publishing data on a 3-year basis. So that's why you see 2016 to 2018. But what we're trying to do is publish recommendations on a yearly basis, so that at least we can get more timely recommendations out, even if we can't get the data, the actual numbers out, because the numbers are too small and would reduce the anonymity for New Jerseyans. Next slide. So, in conclusion, I just wanted to say that, qualitative data is very important, but quantitative data is important, but it doesn't tell the whole story. I'm a practicing obstetrician I still deliver babies. I still see patients every day. And, I listen to the news stories. I listen to, many of the thought leaders. And by and large, what I hear is that patients want to be seen and feel heard. These are some graphics from the Black Birthing Bill of Rights, advocacy organization. And I think that storytelling and hearing the lived experiences of women should not be underrated. Every mother counts, every life matters, Black lives matter, Black mothers matter. And so we can't be satisfied with just not being 47th or just improving from the disparities of Black women not being 7 times more likely to die in New Jersey. We are here to do better, and I'm part of that effort with you all. Thank you so much.
Thank you so much, Dr. Campbell. I'm going to turn things over to Linda Schwimmer next to share a little bit more about other sources of data that we use in the state. Linda?
Thank you. And thank you, Dr. Campbell, for your presentation. In addition to all of the important data that Dr. Campbell just shared, I wanted to share very briefly some further information and accessible data from the Leapfrog group. So for disclosures, the Quality Institute serves as the regional leader for the Leapfrog group. We don't receive compensation for that. I also serve as Leapfrog's vice chair on its national board, and I chair its ambulatory surgery center committee, and those are both volunteer positions. Next slide. The Quality Institute is, as I mentioned, the regional leader for Leapfrog, which means that we support all of the hospitals and ambulatory surgery centers that are reporting to Leapfrog, and we promote its use and discuss its measures and importance widely. Next slide. So Leapfrog has various rating programs. Today, I'm going to be focusing my comments on the Leapfrog Hospital Survey, and in particular on the maternity care aspect of that survey. Although I would just state that there are other aspects of the survey that are relevant to any patient within a hospital setting, but I'm going to focus on maternity, the maternity sections today. Next slide. So how can consumers access the Leapfrog survey data? The Leapfrog survey data is free. It's publicly available. It's on Leapfrog's website. Leapfrog has spent a significant amount of time making it very user-friendly, very consumer-friendly. It has a hover over feature, so you can hover over the section of the survey and see exactly what the definition is. It has a gas measure bar, sort of, you can see in this example on the slide, where you only hit a small, kind of like, or actually this one is sort of like your cell phone, where you're low on battery if you've limited achievement versus you're at full battery capacity if you're meeting the measures. You can go to its website, you can plug in your state, or you can plug in a city, or you can search by the name of the facility, and you can see for each year how a particular facility is doing on all 6 of the maternity measures, as well as the other sections of the survey. In New Jersey, we have 100% of our hospitals participating in the Leapfrog survey. They voluntarily participate, but it gives New Jersey a wonderful opportunity to have a wealth of data and to think about how that data could be used in combination with a lot of the data that Dr. Campbell just went over. For instance, in California, it's the California maternal, their equivalent of the MCQC. uses Leapfrog data. Leapfrog gets that data directly from the California MCQC so that hospitals don't have to report in two different places. Leapfrog also works very closely with the Joint Commission. And so for hospitals that are reporting to the Joint Commission, there's commonality there. So leveraging and collaborating enables Leapfrog to have more timely data. Hospitals report on the hospital survey starting in July of each year, and they can update that information monthly until February when the new year's reporting starts. But it also enables hospitals to update their data so when consumers or others go in, they can see more timely updated data. Next slide. So I think I covered all this, so I'm gonna skip this. Okay, I want to jump in. So there's in the maternity section, there are 6 measures that are reported, and then there's some new ones for this year, but the 6 core measures, maternity care volume, so the number of live births, early elective deliveries, cesarean section rates, episiotomies. There's 2 process measures for screening of newborns for jaundice prior to discharge, as well as prevention of blood clots in women undergoing a cesarean section. And then there's a question about whether your hospital has high-risk deliveries, scheduled high-risk deliveries. New for 2023 are questions about your hospital policy and percentage of assisted births by midwives, policies around supporting and allowing doulas, what you're doing with respect to lactation and breastfeeding supports, percentage of vaginal deliveries or VBACs, vaginal deliveries after a cesarean section. So that will be super helpful information as Dr. Campbell is sharing. Again, this is by brick and mortar hospital and will be, within the past 12 months or the prior 12 months. So this will be fairly recent data in the world of data. And then whether or not your hospital offers postpartum tubal ligation. Next slide. So how's New Jersey doing on these measures? On the Leapfrog survey dashboard, and I will be sharing all these slides, and the slides have the links to the sites that I'm referring to. We are doing mixed. For early elective deliveries, we have improved significantly since 2015. That's the first graph you see on the left. We have a slight uptake during the pandemic, but much below the target of 5% or less. So that is a positive. And I think that that's in part due to changes in the payment system. New Jersey Medicaid and the state health benefit no longer will reimburse hospitals and physicians for early elective deliveries. The second graph here is on NTSV cesarean birth rates, which is defined on the slide. We are unfortunately above the target, which now under the World Health Organization and Healthy 2020 or 2030 is 23.6%. We had a slight uptake during the pandemic and we're at 25.2%. And for episiotomies, we have been doing well. We've come down significantly since 2015, and we are just below the Leapfrog target, which is good. Lower is better. And we are at 4.7. I would say, though, that on all of these measures, there's significant variation across hospitals. And so you can go to Leapfrog's website and you can see these measures hospital by hospital. The Quality Institute also has one chart which has every hospital and how they're doing on these measures, which we will share with you. But there's wide variation across hospitals, and it's oftentimes varies by region of the state. So it's the practice. So at this point, I just want to summarize by saying that we've shared with you a lot of resources, and what we're trying to do is build the foundation of the data, what data is out there, its timeliness. But I want to echo what Dr. Campbell was saying, that it's not all about the quantitative data, it's that qualitative data that we know is also so critical. And this is my segue over to Helen, who is going to be presenting the patient experience survey data. So Helen, please take it away.
Thanks so much, Linda and Dr. Campbell. It's really wonderful to join you at this stage in the conversation. While I didn't put in my presentation a disclosure statement, I do want to just indicate first that I do not have any personal financial conflicts to disclose, but I also want to disclose that I am proudly stepping into this presentation and I'm really presenting the work that has been implemented and designed by a large collaborative and led wonderfully by team members of ours who have moved into different roles. Christine Ivory, most recently, who hopefully you all have seen some of her wonderful presentations, and I'll do my best to step into her beautiful shoes. And also Cheryl Hackett, who really initiated so many of the components of the project that led to where we are today. I shared a number of things in our pre-reading materials, but understand with the many busy schedules represented on this call that it's helpful to kind of start from kind of what is it that we're talking about. So this project that I'll be discussing today, which we refer to as the Maternal Experience Survey, really came out of the state's investment in family health initiatives to create a prematurity prevention initiative back in 2018 under the Community Health and Wellness team led by Nation Hornsby and at the time Alita Jordan. They really wanted to invest, as all of the departments and divisions were being challenged by the First Lady's vision, to incorporate high quality evidence proven interventions for pregnant people who and knowing that prematurity really drives so many of our poor birth outcome data in the state of New Jersey, we wanted to take a look at what we weren't yet doing in New Jersey from a clinical perspective. So we were challenged and worked very closely with a big team of folks to bring together clinical experts from across the state of New Jersey and also nationally to look at clinical interventions. We know that prematurity doesn't have many quality and evidence proven interventions in the clinical space, certainly not to prevent the first premature birth. But we at the time still had 17-hydroxyprogesterone, 17P available as something that was supported. And our team continues even today to support it as a tool within the toolbox of our clinical community to support pregnant people who may experience prematurity or have experienced prematurity in a previous pregnancy. But what we knew we needed to do, especially as we looked at that medication, was really assess what was happening in New Jersey for families, what were barriers to access to the different available resources, whether they be clinical or really addressing social determinants of prematurity and other health conditions that affect pregnant people. So doing that work, we identified across time and experience, as so many of us have been doing this for a very long time, we recognize that many of the efforts that we have to implement change have seasons, and we've seen some things done before, and then we change our strategies and they come around again. So what we recognized as a consistent, effective component of all of those different approaches was that true engagement between individual patients and their provider partners. And how could we better make that strategy of seeing and speaking to providers as part of the pregnancy experience available to women and birthing people across New Jersey. So as we brought the information, as we've shared and Dr. Campbell has shared, the data on what things have looked like here in the state of New Jersey for many years. We were very fortunate to have terrific engagement across multiple counties in the NAACP committees and work groups, and to have them say, we want to be doing exactly what Dr. Campbell ended on, and Linda also noted, telling stories, right? The thing that made the biggest difference when we were speaking to families and individuals was feeling and knowing that their providers cared and were connected to them, and that the experience of not having that kind of acknowledgement and space to be a full person during their pregnancy and childbirth experience really affected the likelihood that they would agree to any clinical intervention, or that they would have confidence that their provider team was invested in their health and their experience. So moving into that challenge for community voices, and we can go to the next slide, we brought a group together, continuing to work with those clinical leaders, and I name them here and thank them each for their phenomenal work to bring us to this point, and many other components of that program are still working today, and the maternal experience survey lives in another space that we'll discuss. So as we got started, we had these amazing clinical leaders as well as the consortia partners. And as we implemented the maternal experience survey specifically, we had partnership from Ascenda and Advocates for Children of New Jersey, as well as our central consortia joining us in this work to disseminate and bring together important task force groups across the state. And one of the materials that you received is a task force toolkit to really help people in communities that haven't yet supported and distributed the maternal experience survey to see how that can come together. What we were very pleased to see, is particularly for the Atlantic City NAACP group, was that they decided as a group to create a Black infant and maternal mortality task force, which exists today. And it was under their guidance and leadership that the survey that I'll be talking to you about was developed, with members of that task force, as well as many individuals, birthing people from across the state of New Jersey. I think we can go ahead on to the next slide. We're going to be sharing a lot of data with you this morning. We know many of you have seen the wonderful presentations about how we got to this point, and I know we'll discuss that more in our breakout session in a few minutes. So I'm going to really dive in now to give you a sense of the data that we've collected. And this information, I want to thank Carrie Millen, who's here with us this morning, for putting together these beautiful slides, and for always responding anytime a group, whether it be a group like this that has a very broad audience, or a local group wants to see what the data for their community is looking like. Carrie steps in and builds these beautiful and easily understood slides that really describe the information we have to date. So the tool was launched in early 2021. And since then, up to even last week, Carrie was looking for data for us for our presentation today. We have seen the completion of the tool, and the tool is broken up into different versions. You can complete it during a prenatal experience and just answer questions related to your prenatal care, or complete the entire tool, and that goes through postpartum experiences as well. As you can see here on the map, we have most counties represented with some surveys completed. And we do know that more than half of our responses do come from individuals who live in counties where there has been an advisory board put together to distribute and disseminate and encourage completion of the tool. Next slide. We wanted to share with you the different types of completion that we've seen. So we did translate the tool in Spanish. While it was designed and specifically focused initially for Black birthing people, we recognize that there's an important experience for people who have primary Spanish speaking and comfort in completing the tool in Spanish. So we have translated the tool into Spanish, and it's available in that format. The other thing to note, and we'll see this on our next slide, I think, as well, and we can go ahead to that. We also recognize that we want to collect stories, that the experience of birth is something that really lasts a lifetime. And And if you go to the next slide, please, sorry, then what we have opened the survey to is really anyone with a birth experience. So I know recently my mother was telling the story of my birth more than 40 years ago. So it's something that we know lives on in people's memories and really affects the way they feel about interacting with the medical system. So while most of the survey results have over 75%, 77% were completed by individuals who delivered in 2020 to 2022 or who were pregnant between 2020 and 2022, we do have responses from individuals who even delivered before the year 2000. So we know those stories and the importance of that experience just lives on for individuals. Next. So this slide represents year one. I know when we were preparing for this, and many folks have seen that broad presentation with all of the data, we did want to show some differences. So we have seen this is that we had 46 respondents in the first year, where we really as a team were out on the street and working with our task force groups in Essex County and Atlantic primarily, although we did have a number of responses from Camden County as well in the first year. This represents the data that we received 46 responses in the first year of distribution. And what we also know, and many of you have noted, many of those of you who have been in other audiences have noted, the ability to break the data that we received down by race and ethnicity does set it apart from other patient experience surveys. So REDCAPs and other surveys cannot always be provided to sites based on race and ethnicity, and this tool gives us that opportunity to break things down not only by response categories, but also, of course, race and ethnicity, which and individuals who are completing the survey can select multiple choices. It's not a single selection tool. And so next slide, we see that in the second year of the survey, we had 170 respondents. We continue to have the majority of our respondents in the select Black or African American as their race category. And we also, in this time, you see that significant jump. We had terrific resources and strategies thanks to ACNJ and some of our ambassadors to really increase the completion of this. So the idea that Black and brown birthing people don't have the sense that their voices are important, we recognized or the priority of the people who might be collecting data, having ambassadors, having people with recent birth experiences, some of whom had participated in our task forces or focus groups in the development of this tool. We employed them and supported their efforts to go in throughout their communities and within our hospitals that were participating in the task force teams to encourage the completion of the survey tool, and saw a significant increase and really very deep experiences shared. We not only compensated, of course, the ambassadors for their work to complete the survey tool, but throughout the collection, folks who completed the survey were given incentives. Were given incentives to complete that once they completed the tool. We shared gift cards with them as the resources we were available to us. In our next slide, we look at age groups. So it's also, I think, helpful to see the distribution of ages for folks who have responded. We know in New Jersey, most of our births do occur prior to 30 years old, although in some counties and areas we have a high proportion of births in the over 30 group. We see a very good distribution here. Where 20% of our respondents fall into what we would think of as younger mothers between 15 and 24 years old. The majority, 57% in that 25 to 34 group, which is the majority of births in New Jersey. And then also 23 in that older, as I was for at least one of my pregnancies, the elder mothers. I think there's a worse term that we use, but I'll forget that for the moment. So we do have a good distribution of ages as well. So those experiences we know do change, whether it's your first delivery and the level of engagement, trust, and confidence can either be enhanced or diminished by the experiences you may have had in previous pregnancies and deliveries and birth experiences. Next slide, please. And that, again, is data that shows our full 2 years of collection. Now we'll go back to our first year. In the first year of data collection, the 46 respondents, we had 76% of them experienced a live birth prior as the most recent pregnancy or the pregnancy they were referring to and completing the tool. But we collect information and want to hear and collect stories from folks regardless of the birth outcome, the pregnancy outcome. So we also split out because we knew it was important for the understanding of the proximity to the birth experience that this survey had, that 11% of those individuals had recently delivered their most recent baby. And then we of course did have currently pregnant people. And folks who had termination. I'm going to go quickly through the next few slides, which really get into the same detail for the most recent year. And then the next slide, I'll go right. I just want to show this here and then skip the next one. But what this shows is the differences in how individuals can select to have their stories shared. And I want to now spend my last few minutes with you just sharing some of the stories and the data around the experiences that individuals shared. So what's really critical to the NAACP group and to our philosophy is that individuals had total control over how this information that I'll now share with you and that we share with our local task forces is used. So individuals can select to share just with the NAACP and the local community. They can say, don't share my story. I want to tell it, but don't use this language, and all the way up to sharing it with their prenatal provider or sharing it with their hospital. So those are important details, and the individuals completing the survey can select different responses for different sections of their survey as well. So we'll go ahead now into the next slides and really start to tell you some of the stories. So I thought it would be helpful to start with some prenatal questions. So the survey asks about if the individual responding thinks that their race or ethnic background caused negative treatment by their care team. And what we see here is 72% of respondents said they did not think that at all. But that another portion, in fact, 3% felt that it had a lot of impact, and 15% some impact. These slides, as I said, in addition to helping you visualize what we're learning today, are also presented. This is the type of slide presentation and data that we present to our local groups, which include hospitals, as well as community groups to really come up with strategies for action. As you can see here, we had two quotes we thought were really helpful to share. So one individual shares that in their first pregnancy, they did have preeclampsia and felt it wasn't explained well. They ended up having a C-section and felt that their pain wasn't acknowledged, and that they felt that when she had a prior pregnancy with private insurance and her own OBGYN, that her concerns were treated differently, and that she was ignored, and that she saw implicit bias present in her care. And these are quotes that Carrie and our team has worked very hard to pull out. We see another individual who shares with us that because of the diversity of the staff and experiences of the team that she had managing her care, she felt that her care was very culturally appropriate, and that she had a place to share and be heard. I'm going to just ask you to skip down to, if you don't mind, to slide 17. And this talks about our post-discharge experiences. These slides will be shared with everyone, and we also have our website where much of this information is also shown. So this slide asks individuals to share with us if they had any adverse challenges after delivery, and some of the stories here I think really reflect much of what we know happens. But when we're able to share these slides and these quotes with local teams where we know these individuals live, the enticement, the energy, and the resources to respond come to fruition much more quickly. So knowing that patients who have these experiences where they feel they weren't heard go on to have either better experiences because they've sought out different care, or to still feel isolated and alienated from the care teams in their area is something that's really important. So we see things that I know, and I have wonderful nurse partners who share that they fear they may have done some of these things in the past in terms of prioritizing their own schedules, not giving women the energy to breastfeed, that they are looking for, and the support, that these are things that when they're interacting with patients at the bedside in the future, these quotes really stay with them. And just because I know we're out of time, I want to share slide 18, where we have some of our beautiful moms, and you can go to our website where their stories are shared. These moms asked and encouraged us to share images of them and their full stories. Those are available at the website. And then finally, I just want to share some of the marketing materials on slide 19 that we developed in partnership, again, with a storytelling focused team and this tool has really helped us to get the word out and have folks understand what the survey is and engage with it. So I know we'll have greater time for conversation, and I saw some questions popping up in the chat. I'll be sure to be ready to address them in the small groups or in other times to come. So thank you all for the opportunity to share.
Thank you, Helen, and thank you all for engaging with us. I know that this is going a little bit over, but it's a lot of great content. We're going to go right to Kimberly, and then we're going to go right from there to the breakout session of your choice. And as Helen mentioned, we'll dive deep into some of those questions and discussions from there. So, Kimberly, I know you're gonna put up your own slides, and right? Okay, awesome.
Is everyone seeing my screen?
We're only seeing part of it.
Oh, okay. Let me do that again. So sorry. Let's see. How about now?
It looks like it's very, very zoomed in, so we can see just a couple of letters on your slides. I don't know if you're able to zoom out.
Why would it be doing that? Let me try one other thing. Oh boy.
While working in the background in technology, I'll take advantage of the small amount of quiet time just to give you some prep for what will happen after Kimberly's session. We'll be going into the breakout rooms, of which there are 2, so you'll be able to self-assign yourself. You'll see the 2 options pop up, and so it's for theme 1, which is the quantitative session, and theme 2, which is qualitative. Kimberly, we're not seeing the slides.
I see that. And actually, Zoom is acting very funny and asking me to sign back in while I'm present. So I'm happy to talk through without slides. And just for us to keep us going, because I know we're a little bit pressed for time. So, because I don't know why Zoom is telling me to sign in when I'm literally present at a meeting.
Why don't, if you don't mind, Kimberly, why don't you do that? But if you want to forward them to Brianna in the meantime, we can try to multitask and pop up. They have popped.
It's a miracle. Good. They're there.
How about
All
now?
right. Awesome.
Okay.
Yeah, we can see them.
Okay, sorry about that.
Go ahead.
Thank you everyone for your patience. Good morning. Hello, I am in San Francisco, so voice is still waking up. So excited and honored to have an opportunity to share a little bit about the way that we approach data and centering that lived experience being critically important. As a conflict of interest disclosure, I have no financial relationships. Earth is a nonprofit project of Narrative Nation, and we are grant funded. So we really decided to create a platform to really address what remains to be an underserved area in maternal infant health around understanding and analyzing experiences of bias and racism in maternal and infant care. That is really what Earth is all about. And so what we know is that when we look at response rates to many hospital administered surveys, HCAHPS, others, that response rates are declining, right? That there is an earned distrust issue that exists between the medical community and communities of color. And so how do we understand the power of having independent community-centered tools? Also, when we're thinking about data, we think about our current approaches. We know that evidence-based is critically important, but for years I've been asking evidence-based on whom, right? And we have to acknowledge that the current evidence base did not disproportionately include Black and other women of color who are currently disproportionately dying under the current system. So how do we create a new evidence base that actually over-indexes those who are being disproportionately harmed by the system and understands that it's not just about quantitative, but as mentioned by my other speakers, that the qualitative piece is so important. We know that anti-bias trainings are critical first steps, but there's no one ever checks back in to see if that has actually improved the lived experience of care for those for whom it's supposed to be helping, right? So there's been no accountability, and in far too many places, this has become a tick the box exercise, right? An assumption that you can train away bias and racism without being held accountable, without checking into the community that it's supposed to help, and that's seems odd, right? And then we have the important work of MMRCs, honoring the work that Dr. Campbell does and the people who do that emotional labor, really, really important work, and honoring that we cannot continue to analyze this problem from the grave, right? We don't want anyone to die. So how do we think about learning from the living, right? So we're about how do we learn from the living instead of looking at data after someone dies. So our approach is really simple. We're centering the lived experience of care. We cannot have a high value health system if we continue to have experiences of bias and racism. That'll never work. And then we have to get to this qualitative experience, this lived experience, so that we're moving beyond clinical outcomes. In our work, we talk to hospitals all the time, and many hospitals say, well, we haven't had a maternal death in 5 years, 10 years, 3 years, as if death is the only thing. Right. And when we only focus on clinical measures, there's a belief that to not kill us or nearly kill us is a win. That is not the win. We deserve a high quality experience and we deserve to thrive. Right. And so there's a whole body of harm, trauma that is being held by Black birthing bodies when we only focus on clinical outcomes. And so how do we include this idea that the lived experience matters? It is not just, well, you didn't die. That is a terrible floor, a terrible ceiling. And so that is basically the floor. And so when people in hospitals tell us this, I say, well, how many of those people have had a 5-star experience? I'll settle for a 4. And how do we define that from Black and brown people and then make that the standard? Right. And that is the work that we're doing. Our work is very much rooted in concepts of decolonizing data, really wanting to have data that ultimately is from Black and brown people, for Black and brown people, that it literally serves the community by giving it to them in ways that matters to them, that it is data that serves us first. And that is part of how we rethink data, that it's not necessarily we get information and it's for academics and institutions. No, the data is for the community first. That is part of our process. And using our platform, we can give real-time, up-to-date information, right? We see a lot of data lags and people are dying within these gaps. So how do we use technology to give us more real-time information, more up-to-date ideas about frequency and patterns? And then we need transparency. We've tried all the things, But what's missing in our birth equity, health equity, all the equity movements is really accountability. How are we being transparent and how are we driving accountability? And so we are clear that we will not achieve equity without transparency. If you think about any broken relationship, right, transparency is the fastest way to trust. It'll be true in your personal relationships, with your mates, with your girlfriends, all of it. And so we have to acknowledge that there needs to be a trust repairing and rebuilding process between health systems and communities that have been harmed. And transparency is going to be the quickest and way to get us there. And so we're really rooted in that concept as how we move forward. So we created Earth, which if you don't know is like the word birth, but we dropped the B for bias, as the first of its kind Yelp-like review and rating platform, where Black and Brown folks and other marginalized groups are invited to leave reviews of their OBGYNs, birthing hospitals, and pediatricians. We start prenatally, asking folks to come and tell us about our prenatal experience, come back, tell us about your birth, come back, tell us about your postpartum visit, and come back, tell us about your baby's care up to the first birthday. So we can really capture this whole perinatal spectrum. Our users can also search reviews by zip code and hospital name. And then on the back end, we turn those reviews into data to work directly with hospitals, payers, and providers to help us learn from the living. Right? What is it that we could learn by having these crowdsourced peer reviews that is now a data set, the first national repository of experiences of care of Black and Brown folks and other marginalized groups as the way that we move forward, right? As the new data, the new evidence that we really need to close the gap with an honest acknowledgement that the things that we have been doing have not gotten any of us where I know we all agree that we need to be on this issue. Right? I'm not willing to settle for just tiny incremental minuscule changes. And I know that we can all agree that we need to think of innovation and we need to think of how we can really move this thing forward. And we hope to be a tool and not the tool as part of all the great work that is going on. I just want to pause and make sure my slides are advancing. Okay, great, thank you. And so our review process, we don't just accept reviews from mothers and birthing persons, but we also accept reviews from fathers, partners, anyone who was at the birthing experience, and doulas and hospital-based midwives. And we have a special icon in the app that shows when a doula has left a review, because we really want to lift up doulas as part of this new evidence base, right? So in addition to our patient reviews, we know that doulas are our eyes and ears for birth. They see a lot. In our doula track, we specifically ask, how many births have you attended at this hospital, right? And so in addition to the feedback that we're bringing to hospitals, we are also showing them what doulas has said, which is at times is an exponential number to that one patient experience. So again, this new evidence base needs to be much bigger than the patient itself, and it needs to include all who are impacted by their birthing experience, right? And then I mentioned our types and our search functionality. One of the things that I think Earth does really well, and one of our goals is around decoding bias, right? You know, because I think providers are taking the trainings, they think that they're doing better, and perhaps that patient is having a different experience. There's a huge disconnect when we speak about bias in abstract terms. Honestly, what's disrespectful to me may not be disrespectful to you. So how do we nail into what are we talking about? What are we talking about? And so we asked very specific questions. Were your pain levels dismissed? Was your physical privacy violated? Were you scolded or yelled at or threatened, which unfortunately is often the number 2 negative experience being reported in Earth? What about assumptions based on racial stereotypes? What about condescending tone? Were your requests for help ignored or refused? So when we go back to systems, we're able to give them detailed information. We have 500 people who said that their pain levels were dismissed. This many people said their physical privacy was violated. We can tell you when they reported that experience and how long it's been. We're looking for frequency and patterns. Frequency and patterns. When we think of something like dismissiveness of pain levels, we know that in pretty much every tragic maternal death story, somebody's pain levels were dismissed. And so how can we leverage Earth as an early warning detection system so that we are being alerted to negative practice behaviors before they become an adverse event? That is the goal. So on the front end, we are giving our community their reviews. We have a review moderation panel of volunteers. All reviews have to be read and approved before they are released into the database for view. Again, giving data back to the community first. The data must serve the community first. If not, we're just perpetuating systems of harm. How do we recognize that Black and brown birthing people are not victims in this crisis? They are powerful consumers. And how do we activate them to drive the accountability that we all need for us to achieve birth equity, if that is truly our goal? And then what is the power of technology to bring some of these power imbalances more aligned with an equitable framework? On the back end, we turn these experiences into actionable data. We literally develop hospital improvement plans. I'll walk you through that process shortly. And then how do we provide hyperlocal data, right? Racism in New York City is not like racism in Birmingham, Alabama, which is not like racism in Northern New Jersey, which is not like racism in Southern New Jersey, right? Very different landscapes. So how are we understanding that hyperlocal information, community-centered information matters? So we're giving you data about your facility and your community, because everyone in your community is a potential patient. And then our long game is about turning our database into a new way of educating providers and supporting and acknowledging hospitals. So we are clear, you can't change what you can't see. We are excited about all the ways that hospitals, health systems, state collaboratives are joining together. But you can't change what you can't see. And you need to see the patterns, you need to see the frequency, and you need to see the details. So in our partnerships, we engage with hospitals and health systems. We ask them to develop a multidisciplinary working group with a CEO sign-off. We do our review collection campaign. We have a high-touch community engagement process. We work very closely with local birth workers and community stakeholders. We actually do this work arm's distance from our health system partners, because quite frankly, we know that they simply don't have the trust in the community, and our trust is our greatest asset that we bring to the process. So we do that work. And then we come back to you to analyze those reviews, looking at what's going well, generating our customized data report, and then developing that hospital improvement plan with that working group. And then we allow implementation period. But after that, we go back in and go back to the community as a test of change, because we are driving community accountability and what has improved, what we still need to work on, right? And then how do we learn more about your system and then embed Earth into the many things that you're already doing that simply need more Black and brown patient experience data? That is our goal. Then we seek to acknowledge the hospital's work. We'll give you a badge that you can be proud of for your website, something to share, and then we report back to the community in a way that suits them around our learnings. Again, taking this approach around data that serves the community, it's not just for health systems to ask stories, but it's for stories to be used for transparency and as a tool for direct change, right? And so we're currently working, we have hospital partners in Detroit, Philadelphia. We're working with the Maternal Health Quality Improvement Network in New York City, where I live. We have 2 hospital partners in the LA area, working with the Louisiana Perinatal Quality Collaborative, as well as UC Davis in Sacramento. And we have a national partnership with the March of Dimes, where we are currently in 2 states. With the March of Dimes, we're doing a different use case. The March of Dimes, as you probably all know, has their own HHS maternal care initiative. They are using Earth as part of their evaluation. So we're going in currently 2 states that will be expanding soon. We're giving them a baseline of community feedback on their birthing and pediatric experiences. Then the March of Dimes will go in to do it, whatever they're doing. We're not involved with it at all. And then we'll go back in as part of their evaluation tool. Again, whatever you're doing with birth equity, how are you getting constant, independent, community-centered feedback, honoring that who is asking matters, and that the best responses need to be independent and coming from a community trusted source, right? And so we're excited about the different use cases for Earth, again, where we work with hospitals directly. Sheridan Blackwell, who is from New Jersey, is now our new head of systems change, is managing that work. Bringing her experience of 10 years working in New Jersey hospitals to now take on our national partnerships. And then how are we working with established equity efforts, state PQCs, et cetera, to just be a part of what they're doing and how we can bring that feedback to their partners. We're currently collecting data in over 800 locations. You can see where we're primarily located. Our national database right now, the #1 negative experience being reported in IRF is requests for help were ignored or refused. #2 being my pain levels were dismissed, followed by condescending tone and rude comments. These vary based on region, but people are sharing the details of this and what it looks like. People do name names in IRF, and we take that very seriously when we see names mentioned in frequency and patterns, because that is information that hospitals need to know. One thing that's been interesting, we're starting to see a high correlation between our nurse ratings and our overall ratings. When you take the birthing, when you go through our birthing track, you're being asked specifically about doctors, nurses, and lactation consultants. And so how do we now better understand the interactions? And I think it's been interesting because we know that there's a lot of talk about doctors and providers, but we're also seeing high correlations between that nurse experience and that nurse, then the nurse being mentioned as part of what made it the best experience or part of what made it the worst experience. And so how do we bring our learnings, not just around the experience overall, but the specific professionals involved in that experience who have the potential to impact that experience? And we know that what's happening at this very vulnerable time is critical to how that mama is going to interact with the health system going forward, how she will interact for her children, how she will interact for herself. And so this is a key time to get it right. And for health systems to understand from a business perspective that turning off a consumer here can have not just lifelong impacts for their ability to seek healthcare going forward, but to use your health system, right? And what we know about Black and Brown communities is that word travels. This is one of my seed ideas. I spent many years working on the ground, going to different cities, working on birth and breastfeeding interventions, and the communities were always talking about where to go and where not to go. The doulas were always talking about where to go and where not to go, right? And so how do we now lift that up as data and information for hospitals to use to improve, but doing so in a way that serves the community first? My vision for IRF and for our team is that IRF becomes our good housekeeping seal of approval for Black and Brown birthing people, that health systems and providers will want to be IRF approved, and that consumers will be looking for this. It says that my community has vouched for the care. And for me, that's the most important accreditation that you can seek, that the communities that you serve say that they feel seen, heard, respected, listened to. That is the most important accreditation there is, right? And so how do we root that in using technology that meets people where they're at? And then how do we use our data to identify what's going well, who are our leaders and how they can help the laggards? What are the best practices that we can glean that can be ideas for replication, right? And then our work is about embedding IRF as a community monitoring mechanism in the many different anti-bias efforts going on, in efforts like in your state as well. How do we center that the community needs to be the voice of how we move forward? And so we're here for an ecosystem for equity that's rooted in the lived experience. And that starts by listening to the community in a robust way, not really around kind of 1 to 2 or even 15 community members, but how do we get to thousands, right? How are we taking crowdsourced peer reviews, being honest and open, understanding that transparency is how we regain trust, and that if we don't decolonize data, we will never have the evidence base to truly serve all, right? We want to remember that, you know, all of our lives are connected, and our goal is to make sure no mother is left behind. I'm happy to stay in touch and answer questions. I'm looking forward to joining others in the working group to talk more. Thank you.
Thank you so much, Kimberly. At this time, everyone, we're going to go into one of 2 breakouts.
Thank you, everyone, so much. I know we cut off many people mid-conversation, midstream in their discussions, and I apologize for not having more time to really dig in. We are going to ask our 2 note takers to give us a quick recap of what happened in the 2 sessions, because I know many of you wanted to be in both. And then we'll give you a preview of what's next to come. So Armini, I'll turn it over to you first to talk about the quantitative data session.
Sure. So for our first theme, our breakout room focused on collecting and accessing timelier and more aligned data across the perinatal period. So a lot of our discussion focused on just the timeliness of data, even though data is published a little bit old and the numbers aren't up to date as we'd like it to be. Sometimes the least that we can do is focused on getting the recommendations out there, even if the numbers aren't out there. One of the major questions that we talked about is how can we use all of these data sources to affect policy change? I know one person from our breakout room shared the work that they're doing in their own organization called Count the Kicks. And they really talked about getting educators involved to relay the data to people who don't have access to data. So that's one example that we can use, just making sure our educators are out there and they're pushing out the information to all groups of people. And again, that just highlights the grassroots efforts that we're making sure the people who aren't in these spaces in public health or in clinical settings, they're having access to the same data that we have and they understand the information. So that's kind of the highlight summary that we talked about for the first breakout room.
Thanks, Tyler. We'll have you go next.
Great, thanks. Yeah, so some of the themes from the conversation in our room on patient-reported data was understanding that there are lags in data that are coming from the hospitals. How can we collect data from the community directly before people actually get to the hospital to be able to help people? And then in addition to that, how can we have people tell their stories, but not tell them over and over again? So using data to assist in that process of helping people to tell their stories once and then continue to share them. Another comment about work being done in other states. So one state is not like another, but we can definitely learn from some of the work that is being done in other states and has been successful. And then lastly, bringing more Black-led organizations into the conversation and not having barriers to folks who are already doing this work. So making sure that they're at the table, making sure that their voice is heard, and making sure that we are not being redundant and creating barriers. I think those were the primary message points.
Thanks so much, Tyler and Harmony. We are in our final minutes together, and we know that there's much more to talk about. I'll turn it over to Linda to wrap up today's session and talk about next steps.
So thank you, Kate. First of all, I want to thank all of our speakers for the obvious time and passion that they put into their work and their presentations today. This data session was really probably the most packed one. So the lesson learned, we need to practice better on keeping to our time, but it's all important information. So thank you for being patient with our presentations. The next 3 sessions are advertised right there on the slide. And then because you were all participating in this, you're all eligible, and we encourage you to attend our in-person convening on March 3rd at the Princeton Marriott. I also want to highlight for all of you that we have the worksheet that we sent out. The worksheet asks you to indicate your name, your organization, what current work you have going on maternal infant health improvement, whether you're interested in working on continuing that work with others, or other additional work, either as a participant or a leader. In order to move your work forward, we ask you to identify partners you're looking to work for, opportunities that you're interested in obtaining, and what your needs are, whether it's training, whether it's funding, whether it's other supports. We're trying to get a sense of really how to connect the dots and to make it very clear to all of us as to who's doing what and how we can help advance all of our work and all of your work. So we appreciate the feedback that you provide through these surveys back to us. That can be sent to Brianna Hansen at the Quality Institute. We look forward to hearing from you and seeing you at the next 3 virtual sessions, and then our in-person session in March. And again, thank you for your patience and time today and your passion and commitment to this work.